as something like this, and congratulations on having pulled it off. I hope we continue to do it. The title that I was assigned here is What is the Role of Modern Hip Arthroscopy in Dysplasia, and What is on the Horizon? An Innovator's Take. Now, you know you're getting old when you get asked to give a historical take. So thank you, Dr. Kuhns, for not calling it a historical take, even if that's what you actually meant. Disclosures. Outline, I will talk about the evolution of hip arthroscopy techniques and some of the innovations that I've been a part of. The first concomitant PAO and scope, and the development of the concept of arthroscopic stabilization, and perhaps some future directions. So these are some of the innovations that I've been a part of over the course of my career, with a little bit of a timeline. And since the title is An Innovator's Take, I'll share one thing I've learned over the course of these, which may be helpful to Dr. Kuhns and Williams and Selly's generation. You all are going to be responsible for the next innovations, and when you are, they will be met with resistance and skepticism, just like the whole field of hip preservation was when it started. And then that will eventually give way to acceptance, sort of like the 7 stages of grief, and finally to the mainstreaming of those ideas, if they were good ideas in the first place. So these were some of the ones that I had along the way. In 2008, the concept of an anatomic labral repair, which stirred up a little bit of a firestorm with letters to the editor and stuff in the journals. Then in 2009, the concept of capsular plication, utilizing our longitudinal capsulotomy, and I'll get into the details of how more. In 2010, we began doing arthroscopy for borderline dysplasia, utilizing the first 2 techniques, anatomic labral repair and capsular plication, with the goal of achieving outcomes vastly different from what had been achieved in that very difficult population prior. And then in the same year, did the first concomitant PAO and scope, and one never knows for sure that something hasn't been done first somewhere else, but I believe we at least had the first publication on it shortly thereafter. And then by 2015, we had refined the technique for labral reconstruction using the knotless pull-through technique, which added to some of the previous techniques in our treatment of dysplasia. Another thing that I've learned over the course of innovating is that the difference between an innovator and a quack is that an innovator at least tries to collect and publish their outcomes and share them with the medical community. So I've tried to do that along the way, starting with a number of publications about the anatomy, and then about several techniques, then about the clinical outcomes of those techniques, and then more recently, in this department of borderline dysplasia, systematic reviews assessing our outcomes and those of many others. So let me dive into it. The first technique innovation was the concept of anatomic labral repair. And the first version of this we called labral base refixation. This was the one that stirred up letters to the editor and stuff. And I actually didn't really think it was a big innovation. I was just trying to come up with a way to have the labrum seal against the femoral head, when we found that some of the early repairs led to eversion of the labrum that disrupted the contact with the femoral head. So we came up with a couple iterations of passing the suture once or twice in a vertical mattress through the base of the labrum to retain that seal. And this was really solving for the technology that we had at the time. Since then, the technology has improved, and now we have things like knotless tensionable anchors with inserter out selective tensioning of repair sutures. So that's made possible different ways of solving the same problem, such as the controlled tension anatomic technique, which you see here in a video. So we can use cannulas, or we can use percutaneous portals, and pass a suture through the chondrolabral junction here in a looped stitch configuration. And by having the ability to control the tension on the repair and the placement of the anchors with curved guides and Dalla portals and percutaneous portals like this one, we can achieve a very good and consistent seal of the labrum against the femoral head. I'm not going to, for this crowd, get into why that's important. I think everybody knows. The next innovation was the capsular plication. So folks who were doing arthroscopy in the early 2000s were mostly starting to make capsulotomies that looked something like this. And then a lot of them were doing capsulectomies, really shaving out a good part of the iliofemoral ligament. Sometimes they realized they were, sometimes they didn't realize they were, but to get visualization, they were doing a good bit of shaving. So the thought was that if we could avoid shaving out the capsule, make a capsulotomy that enabled sufficient access, and then do a plication with an inferior shift, kind of like open shoulder surgeons had been doing for 30 years, then we could actually achieve better stability. One of the things that led into this was my background in evolutionary biology, understanding that at some point we all walked on all fours. And when we did, our capsules were likely straight. And then as we became Homo erectus, we stood up, our hips extended, and the capsule took a twist. It took a spiral. And that spiral is the spiral of the zona orbicularis and iliofemoral ligament that gives the hip a screw-home mechanism. It tensions the more you extend, and it tightens the hourglass around the femoral neck, and it resists anterior translation and external rotation. So if we could augment those things by increasing the screw-home mechanism, increasing the spiral, and tightening the iliofemoral ligament longitudinally with sutures that took appropriate bite sizes and had an obliquity that led to the inferior shift, then we thought that we could achieve a soft tissue solution to soft tissue sources of instability. So next up was the role for arthroscopy in dysplasia. And it's going to tie in the labral repair and the capsular plication in a second. But one of the first roles was complementary to a PAO. And this may be concomitant with a PAO. In some cases, it might be pre-PAO, such as the in-season athlete, or temporary relief of pain until a planned PAO, or the scope and wait and see approach, which is sometimes indicated for cases where you think you might get away without doing a PAO. And then post-PAO for persistent pain due to a labral tear or cartilage flap or residual FAI or overcorrection, which incidentally is how Gans discovered FAI in the first place. So here's a case. This was a 22-year-old, 2 years of right hip pain. D-Gemeric index was quite good. It showed a labral tear. LCA was not 14. That's, I think it was 4. So is arthroscopy alone an option for this one? I think there's a resounding no from the audience. I would not treat this arthroscopically alone. This clearly requires a PAO. However, I was pretty glad that we were also doing an arthroscopy because the patient had a very big labral tear, and I felt quite a bit better knowing that I was addressing it and repairing it. So here's a quick tour through some of the literature, some of the papers we published on this topic. So the first one was combined hip arthroscopy and PAO, indications, advantages, technique, and complications. And this was really proposing the idea. And then the next one was PAO and labral repair after failed hip arthroscopy due to iatrogenic aggravation of dysplasia. And this was based on a couple of cases that we'd seen who had had rather aggressive acetabular rim trimmings at other institutions and essentially created dysplasia. So then the first question was, all right, is there actually intra-articular pathology? So we did a combined study with Boston Children's Hospital with Young-Jo Kim and Beng Yen, and looked for the prevalence of intra-articular findings at the time of arthroscopy, of concomitant arthroscopy and PAO. And basically it was 100%. 100% of them had a labral tear or a chondral flap or both. So there was certainly something to treat. Obviously, later comes the question of how to treat it, and then does treating it matter? But still on the prevalence, we looked at the method of detection and compared arthroscopy versus arthrotomy. No big surprise, it was a lot easier to identify the intra-articular pathology with an arthroscopy than with an arthrotomy. In the arthroscopy, it was in excess of 80%, and arthrotomy only about 20%. We just could see more, very simply. So then we started to look at outcomes. So in this next study, we looked at 23 patients who'd had a PAO and concomitant scope, and we found Again, intra-articular findings in 100% of them. Most had labral tears or chondral injury. 10 out of them had CAM morphologies. And we were able to achieve very favorable outcomes. Still no comparison to doing it without arthroscopy, but again, this is a pilot series. We're early on in the early 2010s at this point. And then we continue to follow those groups. So we published the 5-year outcomes, and then we look at return to sports and find that a very high proportion of these patients can return to sports. And this contradicted sort of the prevailing mythology of the time, which may not have existed amongst PAO surgeons, but amongst the rest of the orthopedic community, everybody pretty much believed that a PAO was the end of an athletic career. And I think most of us in this room agree today that that is not the case. And so these were some of the studies in which we began to show that an athlete could return to sport. Now, labral reconstruction enters in the mid-teens, 2000 teens, and we start refining the technique for the knotless pull-through technique for labral reconstruction, which has made both segmental and circumferential reconstructions a whole lot easier, more reproducible, and quicker. And this led to its application in dysplasia. Here's a quick video showing a completed reconstruction, and the technique allows us to do this, in this case a circumferential reconstruction, without having to measure the length of the defect, because we complete the reconstruction working from anterior to posterior and then amputate the excess graft. In this case it's a posterior tibialis graft. Here, as we take off traction, we see the seal against the femoral head. So subsequently, we looked at the concomitant arthroscopy with labral reconstruction and PAOs. And this opened a new tool in our toolbox for the patients who had hypoplastic labrums or calcified labrums or shredded labrums. So what about instead of a PAO? Is there a role in dysplasia? And I think, as we've pretty much agreed at this meeting, if there's a role, it's probably in borderline dysplasia, however we define what borderline dysplasia is. I think we all agree that in severe dysplasia, the PAO is our workhorse, but there are some cases, and maybe even a lot of cases, who are in this borderline realm where we may think about more than one option. And if we're going to do it, some of the principles that we've advocated have been: restore the adequate labral seal, whether by a repair, an augmentation, or a reconstruction, placate the capsule, and think about the ligamentum teres. I'll come back to that in the future directions. This was our first pilot group, and remember that this was a group of patients who had had very poor outcomes with arthroscopy in the literature. Jay Parvizi published a study that I didn't cite up here, showing just awful outcomes. And most of those patients had labral debridements and capsulotomies or capsulectomies. So probably the scope was, if anything, making them worse. So we were seeking to change that paradigm by repairing or augmenting or restoring the static stabilizers, including the labrum, the capsule, in this series. So this was 26 patients, and we had at short-term outcomes 100% survivorship, so it starts to raise some eyebrows and think maybe we have some options for this group. And then we've continued to follow them at midterm outcomes, and again, still 100% survivorship and durable PRO improvement over time from 2 years to 5 years. And then most recently we published in JBJS the same group with 10-year survivorship, and still well over 80% survivorship and sustained improvement of their PROs. So that leads us to the systematic reviews that Dr. Coons did with me in the last couple of years, showing that basically we have two possible approaches in borderline dysplasia, and the outcomes in the literature show both are pretty favorable. The conclusion in this second one was there are two pretty good options for a lot of patients with borderline dysplasia that both can work pretty well. So then we love options. We love to have a couple things we can offer our patients and have a shared decision-making process with them. So what's on the horizon? Now I'll really raise your eyebrows. The first thing I think to think about is the ligamentum teres. If we're going to try to have soft tissue solutions to soft tissue problems, We've seen that, that there's a high rate of ligamentum teres tears in patients who have borderline dysplasia. We've seen that those who have ligamentum teres tears do worse with arthroscopy than those who do not have ligamentum teres tears. So either it's a harbinger of instability or it is actually a cause of instability. So this is a picture of a ligamentum teres reconstruction, which we do with a technique that's rather similar to an ACL reconstruction. And I think it's something we'll think about in the future. I'll talk about it more in the next talk. We're about to go to Japan for ISHA, hosted by Soshi Uchida, who has done several hundred shelf procedures, arthroscopic shelf procedures. I've only done a handful myself, and have overall been fairly encouraged about the outcomes. The thing that I've been unable to control is how much the body ossifies that fragment, and I've had a case where it resorbed a good bit, and I've had another case where it ossified quite a bit more than what the fragment was. This is an iliac crest fragment here. So I think it's something to think about. I have not implemented this on any regular basis into our practice, but Soshi's published very good results with, again, several hundred of these. So something interesting for us to think about. So in summary, role for arthroscopy in dysplasia, clearly complementary to a PAO, whether it's concomitant or pre or post, and in some cases possibly instead of a PAO, and that's basically arthroscopic stabilization for borderline dysplasia, done by restoring the labral seal, plicating the capsule, and maybe doing something with the ligamentum teres. Thanks very much.